Okay, pressure ulcers are always a heated topic within the hospital. It's always important to make sure that our patients are not developing pressure ulcers and make sure that we're treating any pressure ulcers they might have. The reason they're such a heated topic is because if patients develop pressure ulcers while on their stay in the hospital is not reimbursed for any care provided for that, number one. Number two, they can be a huge source of infection to our patients. As we open up that skin, our skin is our number one barrier to infection. If we open that skin up, we open our patients up to tremendous infection, and they're very painful, they're very hard to recover from, and if they continue to progress, it can be nearly impossible to really reverse or to heal, okay? So let's talk about what a pressure ulcer is and some of the things we can do to help our patients that may have them. So what a pressure ulcer is an excavation in the skin varying in size, okay? And they generally occur due to compression of tissue for an extended period of time. And this compression of tissue is a lot of times going to be over bony prominence. Now, if a patient's sitting in bed for a very long time, that can kind of happen anywhere. But a lot of times what's going to happen is we have our skin here, and we'll have a bone that's kind of right near there. And this subcutaneous tissue that generally would protect us kind of starts to wear, and the bone comes in contact with the surface, okay? Whether that surface is a bed, a chair, whatever it is, it comes in contact with that, and it starts to put our patient at a huge risk for a pressure ulcer. And here you'll see this is actually bone within a pressure ulcer. Okay, so we all know there's a couple different stages of pressure ulcers. So let's talk about some of these stages. So first one is going to be stage 1, okay? What happens in stage 1 is our skin's actually intact, but what we have non-blanchable redness, okay? So here would be our skin, and the patient would have a kind of a red spot. And what we do if we see any sort of red or pink spots on our patient is we need to press on that. If it's blanchable, it's not considered a pressure ulcer, okay? We just need to make sure we're alleviating that pressure on there. If it is non-blanchable, that's actually going to be a stage 1 pressure ulcer. Okay, the difference in that versus stage 2 is we actually have partial thickness skin loss in stage 2. So progressing beyond that red spot, we actually have a little bit of skin loss, okay? And we're not talking anything beyond the skin. At this point, we're still just talking the dermis, okay? What happens in stage 3 is we actually have full thickness skin loss, okay, extending to the dermis. I'm sorry, and here would be epidermis. Okay, so what happens in stage 3 is it actually extends all the way to the dermis and subcutaneous tissue. Okay, so we've extended beyond that protective layer, and we're getting into dermis and subcutaneous tissue that's being affected here with stage 3. As we move on to stage 4, what happens here is we actually go all the way to bone and muscle. And as you can see here, that's what's going on with this patient here is that the depth of it has extended beyond epidermis, beyond subcutaneous tissue, and into muscle and bone. Okay, so this would be a stage 4 pressure ulcer. There's a lot of times there can be undermining and tunneling. What undermining and tunneling is here is, so here would be, so this, let's say this is the surface of the skin, okay? This is the epidermis. Okay, and then down here we have muscle, okay? So this pressure ulcer is eating its way all the way down to muscle. But what the undermining is it actually is underneath kind of what we are exposed to on the surface, okay? So here would be what we can actually see. This is the hole going down into it. And the undermining and tunneling is the pressure ulcer extending underneath the surface, okay? So that can a lot of times happen with these patients, and that can be hard to see. Sometimes you'll actually have to kind of stick your finger in there or a swab and kind of get an idea of how deep it is and how much undermining and tunneling there actually is going on. With deep tissue injury, it's actually subcutaneous tissue injury underneath the skin. So our skin's intact, but what we'll see is like dark colorations, discolorations on the surface of the skin, and that could be a deep tissue injury, okay? Now, how does that differ from unstageable? With an unstageable wound, it could be a stage 3, it could be a stage 4. We're not really sure because this is covered by eschar, okay? So what eschar is, it's a thick, hard, black overgrowth on top of the pressure ulcer. Okay, and because it covers it and it's very thick, we're actually unable to see the depth and the thickness and everything of this pressure ulcer, okay? So that's the eschar that kind of covers up the injury, and it becomes impossible to really tell. So we can't call it a stage 3, we can't call it a stage 4, we have to just call it unstageable, okay? So that's kind of the differences there between the different stages, and we can provide you with this cheat sheet so you can kind of look at it and have this as a reference, okay? So let's talk about some of the incidents of pressure ulcers, okay? But first, let's talk about this picture here. So as you work in the hospital long enough, you're going to see patients admitted with pressure ulcers that really are this large. Hopefully, you don't have any patients in your hospital get them of this size. Hopefully, they're just maybe admissions from outside sources that come for other reasons. But it's very important to provide meticulous care for these patients to prevent further infection and further growth, and hopefully to promote healing of this pressure ulcer, okay? So what this is a percentage of nursing home residents with pressure ulcers. The data is from 2004, so it's a bit dated, but this actually comes from the CDC, okay? So within nursing homes, a total of about 11% in 2004 had pressure ulcers, okay? So more than 1 in 10 patients at nursing homes had pressure ulcers, and this kind of breaks down what percent had what stage of ulcers. So 5% had stage 2 pressure ulcers, 2% had stage 4, okay? So it's something that happens pretty common, and this is just looking at nursing home residents. This isn't accounting for all the U.S. or the total incidence, but this is just saying in nursing home residents, about 11% had pressure ulcers, okay? Now, I'm not trying to make any statement on nursing homes by any means. All I'm saying is that there is a prevalence of this, and it's important to take good care of our patients that they don't develop pressure ulcers. So what do we need to do for our patients that have pressure ulcers? First of all, we do not want to massage reddened areas. If we massage those reddened areas, what happens is we're actually applying more force and more friction on there, and that could lead to pressure ulcer. So if we notice any reddened areas, we really do not want to touch that. We want to assess if it's blanchable or not. And again, if it's non-blanchable, we're talking stage 1, and we don't want to apply any more force or friction in there with massaging that could lead to a progression of an ulcer. We want to assess for malnutrition and immobility. These are two big issues here with our patients. Two of the biggest things that can actually prevent pressure ulcers are going to be appropriate nutrition and mobility. At least turn Q2 hours to get them moving the weight as much as possible. If the patient's able to, they need to adjust their weight in bed every 15 minutes or so. We need to get them up in the chair as much as possible. That promotes healing in other ways as well, but we need to get them moving, okay? With malnutrition, 2 labs we can look at for this are going to be albumin and prealbumin. Those are going to be kind of 2 indicators of nutrition. Those are going to be labs you're going to be tested about as far as nutrition goes. And then we need to assess patient skin integrity. Okay, with every shift change at a minimum, you need to be assessing with so I'm going to say every shift change and every admission, at a minimum, you need to get a good assessment of where your patient's skin integrity is at. Now, as you're doing your turns as well, it's important to kind of check for that. So we need to maintain the skin dry. So if the skin is wet, if the patient is incontinent and urinating and has a pressure ulcer already, that's terrifyingly possible. They're going to increase in size, that pressure ulcer. So we need to maintain the skin dry as much as possible, and then we need to turn our patients, like I said, Q2 hours at a minimum. Okay, so those are kind of the biggest things we can do therapeutically to help our patients with pressure ulcers. Okay, if you have any questions, you guys, please let me know. This is a huge issue. This is very important to understand, not only to help you with your tests and things, but also I want to make sure that when you guys go into the workforce, that our community here at NRSNG, that we're the best turners in the hospital, okay? That's something to be proud of. That's something to brag about, is to be good at turning your patients, because we're going to prevent something that doesn't need to occur, okay? Pressure ulcers don't have to occur. And so by very simple measures of even just as simple as turning your patient often can help to prevent that, okay? If you have any questions, you guys, be sure to reach out and let me know.